Good evening, everyone. We welcome you all to Ortho TV Online. This is a very special website that is important not only for orthopedic surgeons, but for physicians, surgeons, and all doctors who are watching us from any part of India and also maybe the world. So we have to hand over and to conduct this session. I would just like to introduce who all are there with us today. We have Dr. Tushar Agarwal, who will be the moderator of this session. And we also have Dr. Ashish Fadnis, who will be the co-moderator. And we have our special guest, Dr. Kedar Toraskar, who's a chest physician and chief intensivist of Okad Hospital. And besides that, he's also a member of the special task force, which is made by the CM of Maharashtra. And we have Dr. Vivid Makwana, who is basically an orthopedic surgeon, and he is one of the pioneers who started using all the special equipment in his OPD and OT. So over to Dr. Tushar Agarwal to start the session.
Yeah. Hi, good evening to all. First of all, thank you, Neeraj and Ashok, for having this wonderful Ortho TV as a platform for us. Also, thanks a lot to all the audience. Some of you who may have started your practice, and 6 o'clock seems to be like the prime time, or it used to be our prime time of practice. Here, I thank all my co-moderators for being with me, but most of all, my very, very dear friend, Dr. Kedar Toraskar is here. We go such a long way back. From grade 11, we are together. We've always been studying together. And I realize that now he's become such a big person and so much in control of this COVID. I think the first few patients of COVID, which may have landed in Bombay, were treated by him. And currently, he's running a 130-bedded COVID establishment at Wokhart, out of which 32 patients are in critical care. So I don't think, and he's a part of the Maharashtra task force. So any question on COVID we ask, you and I can have an empirical answer, but he has the definitive answer. So we'll try to cover as many practical points as we can within the next hour or so, hoping to improve our practice techniques. This is the flow will be that we'll be asking him questions, he answers, and eventually we'll be putting up some case scenarios which will help us clarify more. So Kedar, my first question to you would be, how are these two new drugs? I can't even pronounce one of them, the Flavipir and the Resdemivir. They have generated so much of excitement, like my RMOs and everybody feels that now we are going to live happily the rest of our lives and this drug is just going to save us. So are they that magical, a drug?
So thanks to Ortho TV and the organizers, Dr. Neeraj, Dr. Ashish, Dr. Vivid, Dr. Ashok, and last but not the least, my buddy Tushar, with whom I've spent almost more than half of my life. Okay, so it's great being on this forum. So let's start with the specific answers. So these are two new drugs which are in pipeline. They are not new drugs. Most of the drugs for COVID are called as repurposed drugs. So they were used for some other purpose and now they have been tried in COVID. So let's come to the first drug, which is Favipiravir. So that's an oral antiviral. Okay, it was originally devised for resistant influenza infection in 2014 by Fujifilm, Japan. And there were trials there for influenza in which it was supposed to be effective, but not that effective. Since COVID has come into picture, this pandemic has come into picture, there are a lot of drugs which have been tried and which have been tested. So Favipiravir, there was a Japanese trial and a Chinese trial which was done on Favipiravir. There are Indian trials which are in the pipeline. Glenmark is marketing it as FabiFlu, and it comes with a 200 milligram tablet. It is basically it acts against the mRNA, the RNA, because COVID is an RNA virus, and it is an antiviral which has shown to have some efficacy in vitro. Now, about the efficacy of the drugs, there are still doubts about the efficacy, whether it really helps. So the initial trials have shown that it may aid to reduce the recovery, the recovery time by around a couple of days. That's it. It is not shown to reduce the mortality. It is not shown to reduce any complication rate. So the bottom line is, should we be using Favipiravir? Now, since we don't have a magic bullet for COVID right now, except for best supportive care and few things like oxygen, CAR protocols, steroids, which work, which have been shown in recent recovery trials. Apart from that, none of these antiviral work. So favipiravir should be given early. Now let's come to the pathophysiology. There are three stages. Okay, the first stage is a viremia stage where the virus, it's an active stage where the virus is replicating and the patient is infectious. So that lasts for around 7 to 8 days, or sometimes 10 days to 12 days also. But beyond 10 days, the virus is non-replicative. So the antivirals work best in the first viremia phase. If you use antivirals beyond 10 days, 12 days, it may not be useful at all. So this drug favipiravir should be used early. It is licensed only for mild infections. Okay, so it has to be used in the first 5 days. That's when you get the maximum results out of it. The problem is pill burden. The first day you have to take 9 pills BD, that is 16 pills, and followed by around 4 pills BD for the next 6 to 13 days, depending on the response. The drug is also not very cheap, so common man may not be able to afford it. It's around 3,500, 3,500 rupees for around 35 tablets. So one tablet costs around 100 rupees. And you may be wondering that whether to use this drug or no, because anyways mild cases get better on their own, like any other viral infection.
And
Okay, so that's about favipiravir. Yeah.
and none of the cases would be presenting so early. So whether you should know that you exactly have it within first 5 days is a big
Yeah,
big
absolutely,
question.
So
absolutely,
Kedar,
absolutely.
so what we are tempted to think is, right, say, let's say we have a COVID patient accidentally in the hospital and he goes back home. So should we prescribe this medicine to that COVID positive patient and their relatives, or should we also take it in
So
case of
I
accidental
feel
exposure?
that we should explain the pros and cons to the patient, as well as if you are a doctor, we have to explain it to you also, that these are the pros and cons. So this is what is known about it. There is no harm in taking it. Cost is affordable, and the best results are in the first 5 days. So if that is fine with them, you can give it. But I'll tell you something. All our doctors who have received favipiravir, including a very close colleague who works with me in the Maharashtra task force, his experience was that he said that we are willing to take anything and everything. Forget about the pill burden, forget about the cost, meaning we will take it. Whatever works, as long as it doesn't have any gross side effects. So you have to look at the uric acid levels. It is contraindicated in gout patients. Okay, you have to look at the basic transaminases, the liver function test, and you have to monitor those. That's it.
So you would want to
Second
do
drug,
you have to do an SGPT and serum
yeah, you have
uric
to do a
acid before,
basic HUT, HGPT, bilirubin, uric acid, the basic tests which are done.
and it has to go on for 2 weeks.
Minimum 7 days. If there is no response in 7 days, you can give it for the next 7 days. But obviously, as I said, the viremia phase lasts for around 10 days. So there's no point in extending it beyond 7 days. So if it's not working for 7 days, it's not going to work for 14 days also. And let me caution you that it is not a magic drug. My personal feeling is that it is a hype drug. Okay,
Right.
and it's basically maybe pharma driven also. So
Are
that
you
is it.
are you feeling that there will be a cheaper generic version of this drug available soon?
Generic one now, currently only Glenmark has been given the license to manufacture it. Hopefully the government should get down the price once it is used more frequently. So probably the government will get down the price. So hope that it becomes slightly cheaper and affordable to a larger population.
So Kedar, what happened to those Japanese and Chinese trials? Means they were effective, efficacious?
They were, as I said, they said that it doesn't change the mortality, it doesn't change the complication rate. What it does is it can reduce the recovery by around 2 days or 3 days at the most. So that's it. So
So
it was not a great trial.
is it like suppose you got exposed to a COVID positive patient, or let us say we operated a patient who post operative comes out COVID positive. Should I give this medicine to all my staff who were there
No,
in the
no,
OT?
no, Tushar. You don't give them. You don't give favipiravir to these patients. You
Okay.
just give for observing for the symptoms. And anyways, now the dictum is that you have to operate with all PPEs. So that's the best protection which is there.
Okay, so this drug cannot beat PP for sure. Means nobody should
Yeah,
feel that they have
absolutely.
got a magic formula.
No, no. So one of the problems with these drugs is that we have a false sense of security. For example, when we were taking hydroxychloroquine for prophylaxis, it gave us false sense of security that, okay, I'm taking hydroxychloroquine, I'm protected. So that is not the protection. The main protection is obviously your basic things like social distancing, cough etiquettes, and proper use of PPEs, especially doffing. So doffing is a time when you can contract COVID.
Okay. The next drug, that
Yeah,
rest.
so remdesivir, again a tongue twister.
Hmm.
Remdesivir is also an antiviral which has found to be efficacious in vitro. In vivo, we still don't know about the drug in great detail. Now, it again was used for SARS and MERS epidemic, but the results were not great for SARS and MERS epidemic because the same virus, the coronavirus, but a different strain, SARS and MERS. Now, Gilead Pharma from US, they have done the biggest trial there, and Anthony Fauci, who is the editor of our Bible Harrison, and he is the chief of the allergy and immunology division there in US, who directs the US president, had made a statement that remdesivir has shown to have some promise, okay, as compared to the other drugs. Again, it's an antiviral, okay. So ACT trial was the first trial which showed that it reduces the time for recovery. So the time for recovery is significantly reduced, okay, by when you use remdesivir. Again, that's the only thing which has happened in that trial. It has not shown any translation to mortality as of now. It has not shown to reduce the complications, but they have translated it to use for moderately ill patients, especially in the ICU, okay, and you can use for patients who are severely ill also. So that is again a caveat, okay, uh, to help to reduce the time for recovery. But still, trials are on for remdesivir. As of now, there is no clear-cut evidence that it is really helpful. But that's one glimmer of hope. Okay, so
So once a
remdesivir
patient
has
is,
some.
so once a patient is in your ICU and he's COVID positive, so you start them all the patient on this remdesivir is a
No,
mandatory.
no. We don't start all the patients on remdesivir. So the moderately severe categories, we give we give the patient's relatives an option because currently it is still not available in the commercial market. It will be available from next week. There are 7 players who have been given license for remdesivir. So we will be getting remdesivir in the commercial market in India from the next week. The cost will be around 5,000 rupees a vial, that is 100 milligram. The dose is 200 milligrams loading dose, followed by 100 milligrams OD for the next 4 days. So 5 days. Initially, it started off with a 10 days regime, but now they say 5 days is as effective as 10 days. So the NEGM trial has shown that the 5 day trial is as effective as the 10-day trial. It is intravenous, so all the patients should be hospitalized, and it should only be used for those moderately severely ill patients. Now,
Means
if
the
they are
patients who are
beyond,
on BiPAP or a ventilator or when the oxygenation level falls. So is there, see, moderately ill is a vague term. So if you can
yeah,
define that moderately ill,
yeah, so I
please.
will clarify that. So, see, according to the logic, again coming back, there is a viremia phase in the first 8 to 10 days. Then comes the inflammatory phase, which is 2A and 2B, the early inflammatory stage and the late inflammatory stage. And last stage is cytokine storm stage, in which you get a cytokine release syndrome, in which you get ARDS and other problems. So all these phases may be overlapping also to some extent, but remdesivir is supposed to be used before they are on the ventilator, okay, because for
Okay.
a simple reason that by the time they reach the invasive ventilation stage,
That
it's
means
too
they are
late.
already in
It's
cytokine
yeah,
storm,
you're
storm
already
phase.
either in a
Right, right.
cytokine storm or in the inflammatory stage, so it's too late. So the dictum for using any antivirals is that you have to use it early. So
Early.
earlier you
All right.
use, better result. So according to me and according to the guidelines, remdesivir is ideally supposed to be used in the 5th to 10th day or maybe 12 days also.
Till
So
12 days.
there's an invasive ventilator on inotropes, again, organ damage, more than one organ, there is no point in using remdesivir. But
Correct.
again, now we don't have anything in hand. So the relatives sometimes force us that you use remdesivir. ये patient को दिया था, ये हम लोग पैसे का problem नहीं है, हम कहीं कहीं से भी लाएंगे, हम health ministry को बोलेंगे, ये करेंगे, वो करेंगे. So it's more of a social meaning a social obligation rather than the drug really helping.
Correct.
Currently, I've given remdesivir only for 5 patients, and uh, I don't know whether remdesivir helped. They were already better because by the time we got a DGCI approval and got the drug, they were already better. So they got the drug after they were better. So the timing is important. 5th to 10th day or maybe 12th day before they go on an invasive ventilator.
Correct.
So
Okay.
preemptively. Now, after we get the remdesivir in the market, the use will be more rampant here. But at the same time, we should not misuse it and use it at the right time. So everything in COVID has to have the right timing. That goes for the antivirals also.
Right.
So, Ashish, do you have any questions regarding these two drugs?
No, not at the moment.
Okay, so we go to the other drugs. No, HCQS has been battered and butchered, so we'll keep that for the last. Doxycycline, Kedar, are you using? Is it useful?
Yeah, okay. So doxycycline came after this Bangladesh regime in which they published a paper saying that they published a case series, not a trial, in which they used doxycycline 100 milligram BD for 5 days, 5 to 10 days, and they used ivermectin 12 milligram once a day for 3 doses. So this was a combination of ivermectin, which is an antihelminthic, and doxycycline. So they found out good results with that. So the only sole reason why we are using doxy is to cover atypical infections, leptospirosis also, so that the rainy season has come in. Doxycycline doesn't have any efficacy against the COVID-19 as of now. There are trials which are going on in India. Sion Hospital, Nitin is doing a trial, and couple of other centers in Mumbai and across India are also enrolling in a trial for doxycycline ivermectin combination. But currently there is no evidence for use of doxycycline. We
But are we
use
hopeful?
doxy.
Are we hopeful it will
Yes,
work?
yes. We don't know. Only the trial results will tell us. See, right now, doxy doesn't harm unless and until you have a hepatotoxicity going on. Okay, and it covers the atypical bacteria. It covers scrub typhus. It covers leptospirosis. Other things also. So sometimes you may miss out on these things. But as an antiviral, doxycycline doesn't have current standing. The
Doxycycline is the reason of using multiple antibiotics or antihelminthics is that when there is a state of pneumonia, there is a lot of other bacterial infections which you might contract because of the low immunity causing. So, is this the reason why we are using doxycycline or azithromycin in the normal case scenario?
Yeah, that's right. You are absolutely right with that. We do use it as an atypical cover, not
Correct.
more as an antiviral there.
Antiviral cover.
So
So,
azithromycin and doxycycline covered atypical bacteria very nicely. So
so let
pneumonias, yeah.
so let us say a patient, we will come of course to the case later, but if we are rescheduling a case because the patient has come out COVID positive, so when we send them home, this home discharge advice can contain doxycycline and ivermectin, uh,
Uh,
or
as per the
HCQS.
guidelines, no.
Okay.
As per the guidelines, no. But my personal take is that there is no harm in doing that because both drugs are relatively well tolerated and we are using both the drugs very commonly outside the COVID pandemic also. We were using it right from the beginning. So if you remember our internship days or if you remember our residency days also, so doxyceftriaxone and artemether was a standard chapa which we used to give for patients who used to come in and then de-escalate as per the. But it is not evidence based. So I wouldn't say that it is evidence based. If the patient is asymptomatic, don't do anything. Don't give these drugs. If the patient is febrile, you can try that, but that is off the guidelines. It is not in the guideline. We'll have to wait till we get a structured trial report.
So azithromycin has the same stands at the same level as doxycycline.
Yeah, absolutely. But azithromycin with HCQS was tried earlier on in the COVID pandemic in the US, and one paper uh, of a big N number, a big N number means 28 patients was published, and that too in mild patients. So that was wishy-washy. And then there were many papers which came in which showed that this is not helpful. In fact, this can harm because there are a lot of patients who come with QT prolongation and arrhythmias with this combination. Personally, when we started using it very earlier on, maybe two months down the lane or 2.5 months down the lane, this combination when nothing was there, we saw almost 80% of our patients having QT prolongation. So we had stopped using it, not arrhythmia, but QT prolongation and bradyarrhythmias also. So instead of tachyarrhythmias, we had seen a lot of bradyarrhythmias. So we stopped using this combination long time back. And then of course there were after that we got evidence-based papers saying that this combination is dangerous. So this combination has been banned now. So HCQS and azithromycin should not be used.
So when a patient is mildly affected and he is under your care as a COVID patient on the floors, what do you give him? What medicine
So
besides
yeah, so
oxygen?
normally these patients don't require admission. Okay, so in the first part of the pandemic, when we started off early, COVID positive was a big thing. COVID, I am meaning it is something it was more of a social reason to get admitted because all the societies will outcast you and they will say that you have to go to the hospital. So that was what's happened in the first part of the pandemic. That mild patients were getting admitted. So for mild patients, now we have a very small subset of mild patients who are getting admitted, that too for social reasons. Mostly they are relatives of BMC people or corporators or whatever, political reasons or whatever, social reasons, or some VIPs who doesn't want to stay at home because of whatever reason. So for them, we give best supportive therapy. So we give vitamin C, we give zinc, elemental zinc, 50 milligrams BD. So we do give doxy if they are febrile, okay, but that is again not evidence based. We rule out other causes of infection or fever, ILE like symptoms, okay. That's what we do, and we keep a very close watch on them. We do a CRP daily in some patients who are symptomatic, okay, and we check their saturations pre and post walk. So they may deteriorate. The deterioration comes after 7th or 8th day. So that is the time when you have this inflammatory cascade, and 10th, 14th day you may have a cytokine storm. So these patients are very closely observed. That's what we do, and if they are admitted, if at all they are admitted.
So if a patient's saturation is all okay and he is admitted with you, when do you discharge him?
Okay, so if there are no symptoms for at least 2 days, 48 hours, no symptoms, the patient saturation pre and post walk. So we also do a post walk saturation. So normally we do a 6 minutes walk distance test in our pulmonology fields, that is for interstitial lung diseases, COPDs, okay, or chronic lung diseases, to see how the interstitium is. We challenge the interstitium by exercise test. That is a walk test. It is not like running on the treadmill. It is a normal walk for 6 minutes. Okay, it may be 3 minutes for elderly people or patients who are decapacitated. Okay, but 6 minutes is the ideal time. You check the saturations pre-walk and check the saturation after a normal 6 minutes walk at home or in the corridor or wherever. And you check for any desaturation. If they are desaturating by more than 4% or the saturations are going down below 92, 94 from a baseline saturation, these are the patients who are going to land up with complications, and these are the patients who have to be kept hospitalized, okay, or if they are not hospitalized, you have to admit these patients and keep a close watch. Now these patients may be helped with a small dose of steroids. That is the early inflammatory stage. This is the clinical evidence of early inflammatory stage.
So Kedar, just elaborate the steroid because they have been put into print media huge and very popularized.
Yeah.
So whether it's Dexa, whether it is methylprednisolone, solumedrol, or just plain tablet medrol, what can we take?
So, first and foremost, again, coming back to the pathophysiology, steroids will work in the stage 2, which is the inflammatory phase. So, viremia, inflammatory, and cytokine storm. So, inflammatory phase is generally after 8 to 10 days. Okay. And that's when your viremia goes off. The virus is no longer replicative. That's the right word to be used. And steroids are only to be used in the inflammatory phase if the patient is hypoxemic. Now that these each and every word in this sentence is important. In the inflammatory stage, that is after 8 to 10 days, if the patient is hypoxemic. Now the patient may not be hypoxemic at rest, the patient may be hypoxemic after a walk test. So that's the earliest phase where your steroids will work. So with steroids, now recovery trial arm, DEXA arm. Recovery trial was the biggest, which is the biggest trial for COVID in UK, and which has shown good results with dexamethasone arm. Now they gave 6 milligrams of intravenous dexamethasone or equivalent oral prednisolone, which becomes around 30 milligrams of visolon, prednisolone, in the patients who were hypoxemic, okay, and received supplemental oxygen, okay, or they were severely hypoxemic and on the ventilator. So they found out that the severely hypoxemic, the results were the best. The mildly hypoxemic also, the results were good. There was a mortality benefit in that. Okay, one third of the patients in the severely hypoxemic groups were helped with dexamethasone, whereas one fifth of the patients in the mildly hypoxemic group on supplemental oxygen were helped with dexamethasone. So dexamethasone is the steroid of choice. But before this trial came up, before the trial results came up, the recovery trial DEXA, we were using methylprednisolone, and we have used methylprednisolone almost for 2 months now. Okay, on based on the Henry Ford paper, Michigan University paper, the trial was done for around 200 odd patients, in which they again used solimedrol, that is methylprednisolone, in a dose of 1 to 2 milligram per kg 12 hourly in the early inflammatory stage, and they got good results. And we also saw similar good results in our subset of patients also. So we are continuing with methylprednisolone because we have got good results. But some of our colleagues have shifted to dexamethasone 6 milligram IV for 10 days. But that doesn't matter whichever steroids you are using. Dexa is still cheaper than methylprednisolone. The only problem with Dexa can be if you are giving remdesivir along with it, there are interactions with remdesivir. So if a patient is on remdesivir with steroids, you can't give Dexa. Methylprednisolone is safer than Dexa because it has drug interactions with Dexa. So that is
So,
the role of
Tushar,
steroids. Okay, that's the role of steroids. So the timing, the agent I told you, and the time duration is around 7 days. Okay, 7 to 10 days. The recovery trial use it for 10 days. The Henry Ford trial use it for the first 3 days BD dose. Then they switched over to a OD dose for the next 7 to 10 days.
So Kedar, one question is, suppose we get COVID, we have decided to home quarantine ourselves. What is the indication that I require admission?
Okay. So if you have more mild symptoms, you need not get admitted. So if you are at home, the two most important things you have to do is observe for worsening of your symptom, and second is do a walk test daily, at least twice a day or thrice a day. So a pre-walk saturation and a post 6 minutes walk saturation. The earliest sign of desaturation, which I told you, you have to get admitted. So these are ominous symptoms. Breathlessness is one thing which is ominous. Okay. Now, breathlessness, before you get breathless, you can do the 6 minutes walk distance test. So early desaturation can be picked up on the 6 minutes walk distance test. And of course, other symptoms like fever, unremitting fever. So we have seen fever almost lasting for almost 12 days, 14 days, and some patients 16 days also, in which the procal is persistently negative, cultures are negative. So it's a viral inflammatory fever. So if the fever is lasting beyond 5 days, if your viremia is lasting beyond 5 days, you have other complications like loose motions, or you are getting progressively breathless, the myalgias are not settling down. So if your symptoms are not settling down in 5 to 6 days and you are getting worse, that's the time to get admitted. Or as I said, earliest sign of desaturation on the walk test.
6 minute walk test.
So
Okay.
breathlessness may be a late symptom. So I say that breathless, you should not wait till you get breathless.
So Neeraj is asking, is there a defined role of HCQS, vitamin C and zinc, or that is also
for prophylaxis, normal patients, not for people who are already infected.
Okay, so let me tell that HCQS is almost out of the guidelines. We have dropped HCQS now from our guidelines. There is a role in community prevention, as you said, but the randomized trials results are still not out. Now, recovery trial, the solidarity trial has dropped its CQS from its arm. The solidarity trial is done by WHO. It has 4 arms. It has a HCQS arm. It has a dopinavir ritonavir arm. It has 2 more arms. Okay, so in that the HCQS arm has been dropped because of side effects and harmful effects. Okay, adverse events. So I don't feel we should be using HCQS for anything. So you should drop HCQS, leave it for our rheumatology patients because of this hoarding they are suffering. So I think it's time to drop the HCQS, and it will be soon manifested in the guidelines now. So MOH guidelines and our task force guidelines are also dropping HCQS. Now
but
the
there was
second
this
drug is
Yeah,
Ashish.
even people working in the hospital should not be taking it.
no,
HCQS
they should not
completely
be
not
taking it.
required.
Yeah, to be very
Yeah,
frank, I am not taking HCQS. I didn't take HCQS for a single day. So that was too early. Okay, maybe I was preemptive, but they should not be taking HCQS.
okay. Ashish?
No, same thing. I mean, I have taken HCQs for 2 weeks now. So, would you recommend not taking HCQs for any healthcare workers who are going to be in the vicinity of suspects and COVID positive patients?
I would recommend that stop HCQS, but there is meaning to be very very evidence based. There is a RCT which is still a big RCT still going on for community patients and for prophylaxis in the community, even for healthcare workers also. So you can keep on giving it till then. It should be a shared decision to the healthcare worker. It should not be that आपने HCQS नहीं दिया और मुझे COVID हो गया करके वो, and ICMR was recommending it. But soon ICMR will come out with the guidelines saying that HCQS is no longer effective.
One question, Kedar, is let us say I have done home isolation, quarantine, and I was doing well till yesterday, and today morning I start developing hypoxia on the 6-minute walk test. By the time I get to a bed, it may be couple of hours because it's so difficult to procure a bed. So should I take steroid in some way at home?
Yeah, you can take Visalon 30 milligrams. Okay, you
Okay.
can take Visalon, prednisolone 30 milligrams. In that case, till you get a bed, and obviously, most of the societies are keeping oxygen concentrators. So that facility till you get a bed, if that is available, you can take that. So oxygen is therapeutic here. One of the few rare cases where oxygen becomes therapeutic because there's no treatment for there is no magic bullet for COVID right now.
So what you give it at 10 liters O2? Suppose I
You
have to
have
do.
to give it till the oxygen saturations are up to
90%.
96%.
Okay.
Okay. So it is you can start off with 4 to 6 liters. You are maintaining saturations up to 96. That's good enough. You don't aim for supranormal saturations. You don't aim for 100% saturation.
But you will advocate that this patient should now be admitted once you have developed
Absolutely, and these
hypoxia.
patients, yeah, these patients should go directly to the ICU. They should not go to the ward unless and you don't have ICU beds. You can keep them in the ward till you get a ICU bed, or you can keep them in the HDU or the ED till you get the beds.
Okay. From the
What
drugs,
about
huh,
what about vitamin C, zinc for normal patients, not COVID positive, for healthcare workers? Vitamin C,
Yeah.
zinc, and D.
So they can keep on taking it. Elemental zinc, apart from being an ino4, the idea is that zinc is an ino4 for COVID. So it has antiviral properties also. The dose is 50 milligram elemental zinc twice a day, minimum 100 milligram. Some of the people are advocating 150 milligrams of zinc. So not many zinc preparations have that. So you have to check out on the brand which has 50 milligrams of elemental zinc. So there is no harm because zinc is supposed to be an immunity booster. There is no harm of taking zinc and that dose, provided they tolerate it. Some of the patients don't tolerate zinc sulfate, but they are a minuscule number. So there's no harm in taking zinc, according to me. At the same time, vitamin C also is in the same boat. Vitamin C has been tried in the ICU in our field for septic shock, intravenous vitamin C. So vitamin C also is an antioxidant and as an immunity booster. So there is no harm in trying vitamin C with zinc.
milligram per day
There
zinc.
are papers for that, but there are no conclusive papers saying that it is an antiviral. But at the same time, there is no harm. So
It
we give
helps in
vitamin C for all our patients, including elemental zinc 100 milligrams for all our COVID patients. So there is some evidence to it, but it is not an antiviral. It may be just an immunity booster. Now, antiviral properties have to be studied. Zinc is an ino4, as I told you, for COVID. So antiviral properties, there are still RCTs which are going on. Our hospital is doing a RCT on zinc. So we are giving zinc to two patients and alternate patients are not getting zinc. And we are looking at the viral load and we are looking at the other factors as the recovery time and the average length of stay.
What about vitamin C dose?
Vitamin C dose is anywhere between 1000 to 1 gram to 2 grams. Minimum dose is 1 gram oral vitamin C.
has vitamin C known in helping resolution of the pneumonia in earlier than without any vitamin C supplementation?
Those
No, we are not seeing that. Meaning, we will require a proper trial for that. So as of now, we are not seeing that.
Okay, Kedar,
Yeah.
you can see this. What
Nahin,
I'm
we cannot see it. You'll have to put off your virtual background.
Virtual background निकलना पड़ेगा.
okay. Anyway, what I was trying to display is a kit which has now come. It's available for roughly 650 rupees. It's a rapid diagnostic test for COVID. Okay, and it picks up antibody. So it gives a control IgG and IgM. Now, do you think it is of any consequence? Does it give any add-on value? Does it have any value currently in diagnosis of COVID?
Okay, so let's go to the testing. Okay, so the gold standard for testing still remains to be the RT-PCR, so real-time PCR for COVID-19. But there are some problems with the real-time testing. As I told you in the beginning, that the false negative rates are as high as 30%. So there are various studies which have documented a false negative rate of anywhere between 8% to 64%, but the average is around 30%. So 1 in 5 patients, your RT-PCR may be negative despite of the patient being COVID positive, despite of the patient having COVID infection. So that's the bottom line. But it is still the gold standard because it is a meaning it is a PCR based test. The specificity is excellent. The sensitivity is not excellent. That's why the dilemma that these are suspected COVID and COVID report is negative. But unless proven otherwise, the dictum in the pandemic is that if you have ILD-like symptoms and if you don't have an alternative diagnosis, any patient should be treated as COVID, okay, till an alternative diagnosis is there. Now, the other test which you have in antigen testing, which ICMR has
जतिन
just
एक वेबिनार में
recommended
हूँ
on
क्या हुआ बोलना
23rd June, that the other tests are antigen testing. Okay, let's come to the other antigen testing. So CNAT, that is the nucleic acid amplification test. Okay, those are used, the gene expert ones which we use for TB. Okay, those are used. Those are rapid tests. The sensitivity is not as good as the RT-PCR, but they can be used because if the antigen test is positive and the patient has ILD-like symptoms, you need not do a RT-PCR. That's what ICMR is saying now. Now
So that's
these will be
available only in
available.
Hinduja. That's available only in Hinduja.
No, it will be available now. ICMR is making it available at all the centers, including the district levels now. So from next week, you will be getting those kits. That is the antigen test,
एंटीजन
Tushar,
किट
not the antibody test. Now let's come. So this is the CNAT and the rapid whatever a rapid NAT test. These are what they are called
That
as.
you have an idea roughly what it will be costing, that antigen test?
That will be much cheaper than the RT-PCR. In fact, the RT-PCR has come down to 2,800 or 2,200 now. It was to start off with, it was
करेक्ट
4,500. Now these tests will be around anywhere between 500 to 1,000 rupees, according to me. The government will be subsidizing these tests, and these will be available all across the ILD centers, all across the municipal hospitals and private hospitals also, which are NABH certified. So all NABH certified hospitals will get an access to do all these tests. Okay, the antigen test. So life will be easier when we get these antigen tests, because getting a RT-PCR nowadays is very difficult on OPD basis. So there are a few centers which are there. Though
So,
government says that we have
so that
1,000 centers across India.
so antigen will be a good surrogate for the RT-PCR.
That's
You
right.
don't
That's
have to
right.
do the RT-PCR.
So
बट स्टिल
no, if the antigen test is negative, that doesn't mean that he is COVID negative. You will have to do the RT-PCR. If the
आरटीपीसीआर
antigen test is positive, you need not do the RT-PCR. Now coming to
आरटीपीसीआर
your question, Tushar,
Antibody.
antibody.
Hmm.
Yeah. So antibody testing. So ideally, if you see any viral disease or any infectious disease, it should be a combination of antigen and antibody testing. For example, dengue. So we do NS1 antigen with the IgG IgM. So that's called as a rapid test, or that's called as a combo test. So ideally, we should be doing the RT-PCR or the antigen test with along with the antibody test. For
एंटीबॉडी
example,
टेस्ट
I have already had symptoms 10 days back. Okay, and I need to know whether I had COVID and whether I am immune to it. I am a healthcare worker. I want to join back. Or for example, you want to join work, you want to start operating, Tushar. All of you are busy surgeons and you want to get back to work as soon as possible. Or I have my frontline doctors in the ICU whom I want for duties. So their antibody testing becomes relevant. Now, there are three types of antibody testing which are there for COVID. The first one is the lateral assays, which are the basic ones, which you told those are the strip ones, okay, qualitative ones. So, yeah, those are useless. So these are bogus kits, okay. They are not validated kits. Lateral assays are not validated. Second is chemiluminescence. Chemiluminescence is better than the lateral assays. Third is the gold standard, which is ELISA. Now the tests which will be available in India are South Korea based, which are validated by WHO. The initial antibody kits which government of India had ordered for were Chinese bogus mal, so they had to be returned. Okay, So now we are getting those South Korean tests, South Korean antibody kits for IgG only. We are not testing IgM right now. Okay. And the second, Abbott and Roche are the worldwide antibody kits which have been used. So they are 99% sensitive and specific. So for any antibody test, you need 99% sensitivity and specificity. Otherwise, those antibody tests are misleading. Okay. So when do you do antibody test? One is to know the seroprevalence. Okay. So now the ICMR is saying that we don't need antibody test for diagnosis. We need antibody test only for knowing the seroprevalence. That is academic. Okay, one. Second is you need, as a healthcare worker, I need to know that whether I'm safe to work in a COVID ICU. For example, I am working in a COVID ICU almost for more than 90 days now. So I need to know whether I'm really infected and whether I'm immune to COVID. Okay, that's one thing. The third thing is for the plasma trial, you need to quantitate the IgG levels. For any plasma donation, you have to have a titer of 10 10 10 0 10 24. So that is the ideal plasma to be given for convalescent plasma therapy. And there are other needs also to know where exactly you are in the time frame of infection. So these are about antibody tests. The most reliable ones, as I told you, are Abbott kits and Roche kits. Abbott kits will be available. Okay, Hinduja has it, but it is not for commercial use. It is just for testing use. But we'll be having all the private hospitals and government hospitals getting these antibody tests soon, maybe in a week's time or so.
So Kedar, they are also blood drop test. You just put.
Yeah, they are. No, the ELISA will be the venous sampling. It will be venous sampling, not the strip ones, not the finger prick.
So the venous sample ELISA test is the gold standard for the antibody
That's
test.
right. That's
And
right.
we'll
The
be
Abbott kits are there.
and we'll be testing only for the IgG.
IgG, that's right. We are not going to test for IgM.
And that is going to tell us that now we have adequate
Immune.
antibodies
Yeah.
and we are immune to this. So
That's
there's a
right. So
fair
they will
chance
keep,
that we
yeah.
will not get COVID again.
That's not so, but you are relatively protected. So COVID, unfortunately, world over, the IgG response was as bad as around 8 to 15% only in infected patients also, even in healthcare workers also. So that's not great news because we may not be totally immune to it. But yes, those people who have contracted COVID are better off than those people who have not contracted COVID.
Because
But if your
probably,
titers are more than 1024, then yes, then you have a good chance of not.
but then is it because that there are many strains of COVID which has been mutating again and again? So that is the reason that the IgG which is formed and we are more prone again,
That's right.
even after infection. Is this the reason for that?
Yes, one of the reasons is that there are many strains which are going on. Even in India, there are more than 20 strains which NIV NIV Pune has found out. So and it's a mutating virus. So you know
Correct.
that the mortality in US, Italy was very high as compared to Bombay. Okay, so they are mutating. Of course, they are mutating, and that is how the virus thrives. So mutation is one thing by which the virus thrives, and that becomes a pandemic.
Correct.
From this, let's go to the sanitation procedures for the wards, floors, ICU and OT. So you had some comment on that by my discussion, and this euphoria about sodium hypochlorite is not very good. So can you just elaborate that, people feel that just washing everything with sodium hypochlorite and we are COVID free. Is that the case?
Yeah. Now let me tell you some basic principles of disinfection. So the basic principles of disinfections are that you have to have a surface cleaning. Now, COVID stays on the surfaces. Okay. So whether it is a plastic surface or stainless steel surface, it stays for 3 to 4 days. On cardboards, it stays for 24 hours. On copper, it stays for 4 hours. On other objects, it stays for variable period of around 2 days. So that is important. And fomite spread is also known as COVID. Phones, your other fomites also. So those surface cleaning is very, very important. And COVID is an enveloped virus, enveloped coronavirus. So that is the easiest to get disinfected or easiest to die. Just as HIV dies with hypochlorite. Similarly, COVID dies with hypo. All enveloped viruses are better than the non-enveloped virus to be killed by any disinfectant. Now, sodium hypochlorite is nothing but bleach, okay, which we used time tested, especially the classical example is HIV virus, which we use. but it has been hyped up. So they say that you have to have a bath with sodium hypochlorite. So that is wrong, because it is dangerous and it is toxic also. It is irritant. It is you can have inhalation of fumes. The principle of disinfection is that you have to first wash the surface with soap and water. Now that is to remove the dirt, the debris, the blood, the excretions, the secretions. If you put a disinfectant on that surface without cleaning it with soap and water, it's not going to work. It doesn't work. So even in a hospital, the first cleaning should be with soap and water or any detergent, and then followed by the surface cleaning. You should not spray it in aerosol. So that's why fumigation is a long lost practice. Okay, we still use the word fumigation, but fumigation is given up. And fogification or fogging, what we call as fogging, again is not a very good practice. Fogging will help only in those areas where you are spraying. Okay, it won't be used in the contaminated areas. Okay, and the principle is that start from the cleanest area and then go to the dirtiest area. So you don't go to the dirtiest area first and then go to the cleaner area first. So that is again one principle. And you have to have a period of at least 1 to 5 minutes, ideally 10 minutes, for the disinfectant to
Right.
act on it. The disinfectant percentage should be proper. Sodium hypochlorite has to be used for surface cleaning in a disinfectant dose of 0.5 to 1%. 0.5 is the dose for blood spills. It can be used as 0.1 also for a non-hospital area. In a hospital area, 0.5% is enough. Okay, that is 500 parts
It's a
per million.
5% solution which we get. So we just do 10 time
You
dilution.
dilute it, yeah. You dilute it, yeah. You dilute it to 0.5%. Yeah, that's right. That's
10
perfect. So
times.
that is good enough for spills. But the bottom line is that you have to first wash with soap and water solution or any detergent, then apply the disinfectant. Now,
So you are
any
saying
other
the soap and
disinfectant, yeah. So,
you are saying the soap and detergent cleaning should be done, and 10 minutes later we should clean it again with a hypochlorite.
yeah, soap, yeah, that's right. Yeah, that's right. So
So
the
this
soap and
concept
water,
of
not 10 minutes, but you can once it is dried, you can use the disinfectant.
the concept of spraying everywhere, you go to Starbucks and somebody is spraying everywhere. All that is not
That's wrong.
correct.
That's wrong. Aerosolization doesn't help. It only helps where it reaches. Otherwise, the idea is for surface cleaning of the frequently touched areas. That's the bottom line. And first soap and water, and then the disinfection.
Yeah,
So we
Neeraj.
actually should follow
Yeah.
this also.
So what I have been following in my clinic is that the sodium hypochlorite is for floor cleaning. Of course, everything is swabbed before it is
Right.
fogged or fumigated. Now,
Yeah.
there are two questions. One is, I am seeing OPD. Patient comes. I have taken all the precautions. Patient comes and sits in the couch. I have removed the chairs so that there are surface areas attached. I have kept a special person who has got a spray with him. That spray has just basically the ethanol spray which we are using as hand sanitizer. The same WHO recommended. He sprays
Right.
everywhere between two patients. Is it okay to disinfect this much, or you need more? Like he sprays at the handles, he sprays at the couch, examination couch, sprays on my table between every patient.
That's good enough. So 1 minute is the minimum time which is required. So that's good
Right.
enough. And ethanol, any ethanol between 60 to 80% or is good enough. So 70% ethanol is good enough. Spirit, like nowadays we are
Yes.
using spirit as a hand wash because you know the multinational corporate hospitals. So they don't give you hand washes. So we are using time tested spirit we used to use in our good old residency days. So that is also good enough. So spirit is again
So
ethanol,
Kedar,
you can use
as
ethanol
I
70%.
so as I understand, we should not spray with hypochlorite. We should spray with ethanol solution, and
No,
sodium
no, no. It
hypochlorite
is
should
no
be used only.
hypochlorite is also effective, Tushar. You
Hmm.
can spray with hypochlorite also, but cleaning is important. So just that not aerosolization. You have to ask your cleaner to clean the surface
You have
first.
to wipe
Wipe
it
out the
with a
No,
cloth.
surface.
but Abhi, now
Yes,
Neeraj
wipe
is
it.
saying in between two patients, he's spraying
Hey,
ethanol.
He
not
can
only this,
spray and just
I'll
wipe
just
out with
correct
a
it.
cloth, clean cloth.
Yeah,
Okay.
not only sprays is so that the surface reaches maximum, and then eventually he wipes also before going.
Yes,
Why?
that's
And
right.
then the patient enters, then the second patient
Perfect.
enters.
Perfect. That's
So this
perfect.
can be followed between surgeries also.
This ideally should see, it is not practical to do that, but obviously you have to clean it. So in surgeries I would recommend that instead of just alcohol, what we are seeing in the ICUs is that when we switch to some person switch just over to 1% hypochlorite cleaning everywhere because of corona, but we saw a spate of bacterial infection and fungal infection, candida auris, which is the worst candida you can get in any ICU. Okay, So we have come back to hydrogen peroxide with silver nitrate cleaning for our ICUs. So I would recommend you to still use your time-tested disinfectant which we were using before Corona, because those kills Corona anyways. Because Corona is a meaning not a very hardy virus since it's an envelope virus. So keep
What
on
do you say
using
about
For OTs, I would recommend to use your regular disinfectant. We use H2O, hydrogen peroxide with silver nitrate, which is good enough.
what about quaternary ammonium compounds? Are they good
You
enough
can use
to?
that.
They are
So,
good
You
enough.
Kedar,
can use that.
Kedar,
They are also good enough. So
so
as I
Kedar,
said, the bottom line is continue to use what you are using before. Don't change over
Correct.
to hypochlorite just because of that corona fear. Because corona is not a hardy virus. Meaning, go back to your basic cleaning in your OT.
Yeah.
And again, as I said, cleaning with detergent and soap first, and then surface cleaning with whatever agent you have. That is important.
so Kedar, what about UV light?
Okay, so UV light again is not time tested for corona. They are saying that to kill corona, you have to have a different wavelength, a different emitter, okay, and you have to have more than 300 nanometers of UV light. I don't know the technical details of UV light, but the papers say that UV light is still in the pipeline. It is not validated. So if you say that UV light mere paas hai and UV light will wipe off the corona, yeah, so no,
No,
that is
actually,
not
the
the case.
concept behind UV light, which I have just studied and I have been reading papers about it,
Yeah,
is
yeah,
that the wavelength of the UV light should be anywhere between 255 to 350. That is
right,
what is recommended.
right.
Secondly, UV light is not going to penetrate inside the surfaces. Suppose if you keep a wallet for UV sterilization, it is just
Hmm.
a surface of the wallet that it would sterilize, the place where the light reaches. It would
Right.
not reach. If there is a shadow, if the black paper is there, then the UV light is not going to penetrate that and it would not sterilize that.
Perfect, perfect.
So that is how it works. And
Yeah,
there are certain articles means for sterilization, like mobile phones or certain things which we cannot wet it, or we cannot wash with soap and water. So those certain things, if possible, then what substance should be used, like mobiles especially, what can be used to clean them?
so
What is
again,
your suggestion?
first is a detergent. If you can use a small soapy solution, okay, if your mobile is waterproof, that's the ideal thing. Okay, that's the ideal thing. So the precaution is that don't carry your mobiles to your workplace. So again, we before the COVID era also we had papers which said that fomites, especially your
The
mobile
maximum
phone
on the
during
mobiles.
the surgery, are a rich source of infection, and that is very very true. That is very very true. So
If we
leave
if
your
we keep
mobiles
the
outside. That's the ideal thing. If you can, if you want to carry your mobiles to your workplace, okay, which is sometimes practical, then if you can wash the outer surface with a small detergent and then with the alcohol wipe. So what we do is we wipe it with a small alcohol wipe and then dry it off. It dries it off on own. Within 10 seconds, it dries off. So alcohol is a good sanitizer for
so
mobile
will
phones.
keeping it in a formalin chamber sterilize it?
No, no, formalin chambers are dangerous for health.
Dangerous.
So if you will have formalin related side effects. So our time tested good old anatomy days in GS, that was a time when we were exposed to formalin.
So
So
in
formalin should
sanitation,
not be used because it is toxic. Of course, it kills corona. So, but it is toxic to human
so
life.
one last question on the sanitization. The in nursing homes they are using plastic PPEs as reusable PP, and they are fumigating it. They are opening it and then fogging it and then asking their people to reuse. Is that the correct way of using it at all, or
Yeah,
is
yeah,
that a bogus way of doing it?
yeah, that is absolutely bogus. It is not to be used. And now I was reading in the papers also, and we are seeing our vendors. Most of the businessmen have gone in the have reverted to business of PPEs and masks and all those hand sanitizers. So PPEs now are as cheap as 150 rupees, and if you start manufacturing it, or if you know of a manufacturer, then uh, then it's easy. So the disposable ones are the best. Reusable ones may be dangerous. So we don't advise for reusing those PPs.
Neeraj, what?
So this is what I'm showing. This one mobile company guy who sells covers mainly, and
Yeah.
he had sent me these phone cleaning wipes. It's same as Clorox and Lysol. What I understand is Clorox is sodium hypochlorite and Lysol is something like a quaternary ammonium compound.
Yeah, so as I said, corona is not a hardy virus. It is killed by anything and everything. So outside the body, in the body, it is a Pandora.
So with this, we'll try to go to some cases. We do have some time remaining. Meanwhile, if you have any questions while I'm
Ashish, you have any questions?
No, I think we're okay. Kedar has answered everything that we would want to ask. Yeah.
So
Let's come back to the one.
from a practical point of view, would you advise to wear PPE in the OPD also?
Yeah. So that's a very
Orthopedic
good
OPD,
question.
that is where we are
Yeah.
monitoring the patient, no fever, no cough, and we are not seeing those type of patients.
Yeah. So, see, in a pandemic, the maximum danger is not in the ICU. The safest place to work is a COVID ICU. The
Exactly.
reason one for that is that by the time the patient comes to the COVID ICU, they are in the inflammatory phase post 10 days. Second reason is that we know the imminent danger, we see the imminent danger. And third thing is that you are donned with all the PPEs. So COVID ICU and COVID wards are the safest place to work in. OPDs are dangerous. Our respiratory OPD and ENT OPD are the most dangerous because of obvious aerosol generation and because of transmission and because. But in your OPD, Neeraj, I think you should be using at least the N95 mask. I wouldn't say surgical mask because N95 gives you a better protection. Okay, so N95 mask and a shield, at least those two things, and you stick to your etiquettes, the respiratory etiquette, the social distancing, and as you rightly do, you clean in between the patients. So you clean the surfaces in between the patient.
so we were
There
told
was, yeah, just a minute, Tushar. Let me finish with this OPD first. So there was this COVID discussion few days back. I don't know how much it is true. That see, we have to live with COVID, and today or later, the COVID cases are going to be either there very minimal. So how much time we are see social distancing certainly will not be possible in the OPD. There we have to examine the patient after all. Though I am wearing gloves every time, I am changing my clothes. My hospital clothes are different, and my home clothes are different. So I change them when as soon as I reach the hospital, and I change them back when I wear gloves. I wear double mask. One is N95, one is a cloth mask, and an eye shield. And I wear gloves and I throw away the gloves and either use sterilium between the patients or I wash my hands if there are 2-3 patients have gone by. So now my issue is that how much time can an asymptomatic carrier of COVID will take to transmit the virus to you? Is there something like this? The risk increases as the time increases. He's sitting in your cabin.
Yeah,
If
yeah.
he's wearing a mask and you're also wearing a mask.
Yeah, so wearing a mask reduces the transmission. So both of you wearing a mask reduces the transmission by almost more than 70%. You wearing a mask will reduce the transmission to 40%. But if the patient is also wearing a mask and a good quality mask, then it will be almost 70% of reduction. Now, your question, there will be asymptomatic carriers, okay, or patients who are pre-symptomatic before they develop overt symptoms, okay. Those are a good subset of populations. And the asymptomatic phase is the worst phase because that during that phase the transmission will be the highest. I'm not talking about the completely asymptomatic. I'm talking about the pre-symptomatic, those who develop symptoms later on
Later on.
and are
Yeah.
asymptomatic when they reach your clinic, Neeraj.
Right.
So those patients will be very, very dangerous because the infectivity is highest in that period and the
Right.
next whatever 5 days. So the viremia is highest in that, and that is the time when even when they speak, they can transmit the virus to you. So it is not foolproof. Okay, you still you may contract the virus with these asymptomatic patients. And the other thing is that the patient is not going to tell you if he is symptomatic, or the relative is not going to tell you if he is symptomatic. They will hide it. Obviously, they will hide it because they are desperate to show a doctor. And if you say that no, you can't come inside, they will hide the symptoms. And the same goes for COVID patients also. We are seeing a lot of patients who have an inertia of going to the hospital to get the test done with this, and then they will be a social outcast. So that is a real problem. But you have to take all the precautions. What you're doing currently is perfect. Regarding gloves, I would advise you to either change your gloves after each patient or not to wear gloves because gloves itself can be a carrier of infection. And
Yeah, I'm
especially
changing
while
gloves after every patient. After every
yeah,
patient, the
then
gloves
that's
is
fine.
thrown out.
Then that's fine. Then that's fine. The other option is hand washing with a detergent or using a sanitizer in between.
So
Is it
what?
equally effective, the hand wash and the sanitizer, which is more recommended?
And what?
See, as I said, both are different. So, if you don't have a sanitizer, you can hand wash with detergent. That is equally effective. It is not mandatory to use the sanitizer. So, it again gives you a false sense of security. So, hand washing is as good, okay, that with any soap or detergent, any soap will do.
Yeah, I prefer sanitizing because it is faster.
Yeah, that's right. So, but you have to sanitize at least for 40 seconds and those 7 movements for at twice. So, the seven
Right.
movements should be at least twice and it should be 40 seconds,
40
What
seconds.
not
what I
just
feel
5 seconds.
is that you wait for the sanitizer to dry. I think that is
That's right.
that's the best
So
way
you
to.
wait for the sanitizer to dry. You take two helpings of the sanitizer and use those 7 movements twice. So it becomes almost 40 seconds. Okay, 20 seconds for the first 7 movements and 20 seconds for the second part of it. So by the
My
time you
second part
are
of the question was, yeah, sorry. My second part of the question was how many minutes? Basically, this is the time limit which I should be spending in the OPD. See, what I do is that I see to it that it's less than 5 minutes, so that after 5 minutes, either I walk out or the patient walks out.
yeah. So that's right. So 5 minutes is a decent time. So the longer the time you spend with the patient, more chances of you getting transmission of COVID through the patient or you getting the
So
COVID
that
through them.
means I just spoke to a physiotherapist and she has started working very actively. So that's very dangerous for them to spend 30-35 minutes doing one session with the patient.
You have to discourage that. So in the ICU, we have banned non-clinical staff. We have banned physiotherapists also because for their own safety. So
Hmm.
unless and until it's absolutely mandatory, we don't call them.
It's about the number of air exchanges that happen in a room, especially when all the rooms are air conditioned. There is no air exchange that happens. The air is recirculated. So if the air exchanges happen frequently, then that risk of transmission definitely reduces to a very great extent.
You
That
need
is
a
what I
filter
think.
for that, huh?
Absolutely, absolutely.
Means
That's right. So
you
that is
can
the
put filters
principle
on
of
your
any
AC.
negative pressure isolation or positive pressure isolation also.
No, if you have a window AC, the air circulation is coming from outside. That you can decide
No,
whether
no,
the
no,
air.
no, no. Neeraj, you are
No, he's
mistaken.
talking about
It is the air which is circulated. See, there are two modes. When you want the fresh air to come in, there's a different mode altogether. So when you do that, the cooling
Right,
definitely reduces. When the cooling reduces, you want
right,
it to put it to the mode where the cooling would be more. So the air is
right.
recirculated. The cooler air is only recirculated. That is how it happens in the window
Okay.
AC or whatever AC.
yeah. So the bottom line is that you have to service your ACs properly. That is
Correct.
also very important. Apart from the air exchanges, so AC servicing should be proper.
Right.
Uh,
Okay,
अभी
Tushar, you
अपना
can go ahead with the
so the
cases.
split
Yes, sir.
ACs which we have, can we fit HEPA filters on them? The split ACs.
So HEPA filter is a overkill for the OPD. It is fine for the OT complex, okay, or for the ICU complex. But HEPA filter for routine use, it is exorbitantly costly. So our honorable CM had asked this question that can we put a HEPA filter for our cars? So that is not indicated. That's not necessary for the cars or public places or outside a healthcare setup. But in the OT, Tushar, definitely yes. HEPA filters,
HEPA
yes,
filters
yes, in the
will
OT,
help.
operation theaters and ICUs maybe.
Okay. So this is an actual case. This was a 80-year-old lady who had not left her house for over 100 days. And she fractured her upper tibia at home, and it was an unavoidable surgical situation. So she was admitted. On day 2, we came to know she was COVID positive. She has absolutely no symptoms with a perfect SpO2 all the time, 98%, no fever. She was anemic, for which we had given her one PCV and waiting for the COVID report to come. Now, what do we do? Do we operate her? Do we send her back? Do we send her back for home quarantine, or we wait for the BMC to come and take her decisions? And now, if all this works, when is she fit to be operated again?
Okay.
That is the
So the history is unusual
that she
because
is.
she has not left the house, but now we are seeing more and more cases like that. They have never
Yeah,
left their house, and they are in home quarantine, and still people are getting COVID. The reason is that some members of the family are going out. They are asymptomatic carriers, and they may be transmitting the COVID infection to this vulnerable population. Now that
Correct.
80 years is very important, the age. If you see the statistics worldwide, more than the more maximum mortality rate is in the higher age group, that is 60 plus or 65 plus age group, whether it is one, whether it is Italy, whether it is US, or whether it is India, or it is Mumbai. So the age is important. It is an important risk factor. Any age above 60, the complication rates are high and the mortality is high. Now, it is not important. The travel history is no longer important since it is a pandemic now. Previously, travel history was important. Okay. Now she has no symptoms, asymptomatic, and the saturation is fine. So you mean to say that she is asymptomatic and there are no ominous signs here,
Huh.
but she is COVID positive. So
So we did the
obviously,
COVID test
we
only because she was pre-operative.
yeah. So obviously, the first question is that how emergent the surgery is. So if the surgery is something like a limb-threatening or life-threatening, obviously you have to operate in whatever conditions using the maximum PPs and aerosol preventing procedures you have. If the surgery is not urgent, okay, you have to conserve this patient. Now, how long you have to conserve? It is at least a month, at least three to 4 weeks. That is the time when the inflammatory cascade and the inflammation is significantly less. Okay. Now, and by the time the patient also is non-infective, okay, that period. Now, sent back home, I wouldn't send her back home because she's 80 years and she has a fracture and she might develop secondary complications like DVT and PE. And
Correct.
COVID is one area where you have a COVID coagulopathy. These patients are prone for DVTs, pulmonary thromboembolisms, and even arterial events also. So we are seeing a significant chunk in the ICU who have this COVID coagulopathy. Okay, so definitely not home. She will be on DVT prophylactic dose wherever she is in a hospital setup, preferably a COVID hospital facility in a single room. You don't wait for BMC, obviously. Home quarantine, no, this patient should be in the hospital, not in the ICU, but in the hospital. Operate again, as I told you, at least 3 to 4 weeks. Okay, if it is not an emergency surgery.
Yeah.
Does this patient require antiviral? No, the patient doesn't require anything if the patient is asymptomatic. Best supportive care, vitamin C, zinc, best supportive care, and observe for ominous symptoms. I would be doing a walk test if this 80-year-old is able to walk. I will do a 3 minutes walk distance test also, not 6 minutes, but 3 minutes also, and observe her closely for any deterioration.
So when she comes back, we will do a HRCT and a COVID test. If both are negative, then we'll operate.
See, once she comes back, it is a time frame. So if the time frame is beyond 3 weeks, anyways, then obviously most of the cases the RT-PCR will be negative. But as I said, in subset the RT-PCR still may be positive. That doesn't mean that she's infective. Okay, but most of the centers won't operate if it is not an emergency surgery because the RT-PCR is positive. It doesn't mean anything. There, your antibody titers will help. There your IgG will help you. So even if the RT-PCR is positive after 3 weeks and 4 weeks, and you want to operate her, prove that the IgG titers are significant and she's in a non-infective state. Now something more on the RT-PCR. RT-PCR also gives you something called as a CT. Okay, CT is not a CT scan. CT is the cycle threshold. So cycle threshold tells you whether the virus is infective or not. So any cycle threshold which is above 33, that means that it is a non-replicating virus. And now ICMR has made it mandatory even for private labs to tell us the cycle threshold now. So probably from the next week, we'll be getting the cycle threshold. It's something like a viral load for HIV. So telling you in simple terms, it's something like a viral load for HIV. So the cycle threshold is an important thing in RT-PCR. So they have to mention that whether it is detected or non-detected. And if it is detected, this is the cycle threshold is so much. So if you know that the cycle threshold is 33 and above, and she is IgG positive in a significant titer, though she is RT-PCR positive, you can still operate. Okay. The CT scan, if she is asymptomatic, CT scan is not required because she is already COVID positive. If you want to quantitate, if she is breathless, definitely a CT scan will be indicated here. Otherwise, she is COVID positive, so you don't have to do a CT scan if she is absolutely fine. It is an overkill.
Kedar, can I
So
ask a question?
Yeah, sure.
Yeah. So, I mean, going back to the first case, I'm just digressing slightly. Now, what if this was, let's say, they changed the situation slightly in two aspects. The first thing is that this is a fractured tibia, but it came with some kind of a vascular injury. And as you said, this surgery was an emergency, and we had to take the patient.
Right.
If this patient was taken as an emergency, now I know that there's a paper from Lancet which says that the risk of complications for these particular subset of patients who are COVID positive and undergoing surgery is significantly high. I wanted to ask you, are you seeing the same sort of pattern in Bombay as well, that our patients who are COVID positive, who either undergo a gallbladder surgery or let's say a delivery and are COVID positive, are they having a very stormy post-op course?
Yeah, they are having a stormy post-op course. We had operated on an acute abdomen, and he that patient had a stormy course. He survived, but he had a stormy course. So that was one-off patient. So, but we are getting case reports like this from other hospitals and across the world also, as you rightly mentioned, because the inflammation is the thing which kills. So it's the is the immune response which kills, and this immune response is exacerbated by the surgery. Okay, so
Right.
surgery itself is a stress, and the immune response is exacerbated by the surgery. But as I said, if it is life-threatening or limb-threatening, okay, you have to operate.
Yeah.
So you don't want a dead patient.
Yes. So if this patient, let's say now this patient is completely asymptomatic when it has come to us with a fractured tibia, what if the COVID test was not done and we decided to proceed with the normal course of event, that we assess the patient clinically, saturation is maintained, no symptoms, we do a surgery. So what is the outcome for such scenarios where the patient actually is positive, but we have not tested, and then we just still go on ahead with the surgery?
Yeah, the same thing. That the post-op complications will be very, very high. So they will be high. The mortality is obviously high in such cases. If you
Because
operate, it's the same thing. That the risk for you is very, very high. So you have operated without knowing the COVID status of this patient. The risk to the healthcare worker is equally high. Your anesthetist, your whole team will be very, very high. And in orthopedic surgeries, you use your pneumatic drills. I was talking to
Yeah.
Tushar about your technical terms as to what is the drill, or what is the reaming drill, or what all you
Yeah.
use. So in your case, the aerosol generation procedures are very, very high.
So what is the, I mean, do these asymptomatic patients also have a significant amount of viremia? I mean, is
Yeah,
viremia there?
so yeah. So there was a controversial WHO statement that asymptomatic patients don't transmit the virus. That may not be absolutely the gospel truth. Asymptomatic patients who are pre-symptomatic, as I said, they are currently asymptomatic, but they are supposed to develop symptoms later on, or they will develop symptoms later on. They are in fact very, very highly infectious.
No, infections from a respiratory secretion point of view, or even from a drill and viremia point of view. I mean, if we are putting
Yeah.
a wire or so, we generate a lot of aerosols there.
Both.
Both.
So respiratory secretions and both. The only thing where you don't have virus there is your muscle. So muscle is relatively spared.
Right.
So wherever you the idea, the scientific, the pathophysiology behind this is that the virus attaches to the ACE2 receptors. So is
Ah.
wherever you have ACE2 receptors, the spike protein attaches there. So whether the maximum is in the lungs, the pneumocytes, then comes the vasculature, your arterial supply, your venous supply, and you deal with the vasculature also all the time. Then the gut, okay, then the gut.
What about the bones? When we usually drill and do things, so it is usually the bones from an
Yeah,
orthopedic viewpoint. So
yeah.
does viremia is also present in the
In the
bones?
bones, yeah, bones, but not to the extent of the other organs. So
Correct. Okay.
muscle is relatively spared, followed by the bone. But bone, yes, definitely.
Mhm.
So
okay,
this patient could very well be have been COVID negative if we would have tested her. You know, she must be one of those. She could be one of those 30% and could have turned positive later on also.
Yeah, absolutely.
Okay, or she's a, let's say she's a true positive but has come as negative. So in that case, whatever surgeries we are doing, do you advise us to ask the patient to self quarantine themselves irrespective of their post-op status, whether they went home on the third day or the fourth day, to
So
prevent
after the
them?
surgery, you're talking when
Yes.
you are postponing the surgery.
No, after the surgery, post-op you've done a surgery,
Yeah,
the patient was
absolutely,
quite negative.
absolutely. So
Yes.
all post-op patients are a high risk to get the infection themselves.
Right.
So it's best to avoid a lot of traffic. Okay, only one person goes and comes out. So it's best to avoid a lot of contact with people. Okay, and it's best to remain isolated for at least a period of 10 days or whatever. So the basic things can be done by just one personnel or one family member. Okay, that's the ideal thing. Absolutely. Meaning you have to take a lot of precautions in the post-op period.
Either between a COVID test and an HRCT, which is more important?
Now, both are not mutually exclusive. The gold standard is RT-PCR, but as I said, the sensitivity of RT-PCR is not very great. 30% false negatives, 1 in 5 will be false negative, and still the patient may be having COVID. So what people are doing is they are doing a combo. If the RT-PCR is negative, they are asking for a HRCT test. The the logic is that it affects the lungs predominantly as a single organ, and the sensitivity of picking up early COVID is as good as 88 to 90% with a HRCT test without a contrast. So a lot of hospitals, corporate hospitals, are doing that. Okay, so if the RT-PCR is negative, it will be worthwhile doing a HRCT
HRCT.
test before you proceed.
So
Because
the
even if you do a,
combination of
yeah,
two, we can be almost certain that the patient is COVID negative.
yeah, not 100% certain, but to a good thing, to a good extent. But that doesn't mean that you don't use your universal precautions for COVID, which includes a complete PPE. So don't let your guard down. The bottom line is don't let your guard down. Even if it is a 5% chance that this patient still might be positive and in the window period, okay, and it may be very early for the HRCT also to pick up and false negative on the RT-PCR. You don't let your guard down, because your orthopedic is one field where you have a lot of aerosol generation, and transmission during the surgery is very, very high. So I would say that you treat all the patients as COVID positive.
So, coming back to some questions which Ashish wanted to ask is, suppose we keep feeling malaise and this, tiredness and fatigue. How do we come to know whether we are having COVID or we are not having COVID? When should we get ourselves tested?
Yeah, so as I said, in a pandemic, unless proven otherwise, all these symptoms are COVID. Okay, so even if you have diarrhea, it might be COVID. So that's the dictum in a pandemic. But as you rightly said, even we as ICU intensivists have these symptoms like malaise, and if the symptoms are protracted, okay, then you definitely opt for a test. If it is 1 day malaise and then you are fine the next day, or if you have some throat irritation or sneezing and you are fine the next day, it doesn't mean anything. We have seen that the N95 mask itself is allergogenic. So we have those particles, and a lot of our doctors and nurses are allergogenic to the N95 mask. So you get sneezing after immediately putting on the mask, but that is short lived. But if your symptoms are persistent for more than a couple of days and they are progressive, you do that, you get yourself tested.
Okay, and so we have access to HRCT. So which should we go for first? Do an HRCT or do a COVID PCR?
See, the COVID test, the turnaround time in the best of the labs is around 12 to 24 hours. Now, some
Hmm.
labs are giving a positive report after more than 24 hours. So there is a lag in that. So anyways, if it is a non-emergent surgery or not a life-threatening, limb-threatening surgery, you have to wait for more than 24 hours. Okay, so I would recommend, if the patient is affording, get a HRCT test done, or if you want, you can might as well wait for the RT-PCR test, because 1 in 5 patients may turn out to be negative there. So the prudent method will be first do RT-PCR, wait for the RT-PCR test. Okay, if that is negative, get a HRCT done.
If that is negative.
Yeah.
Okay. Okay, for
If that is
ourselves.
positive, you need not do a HRCT, Tushar.
Suppose you are getting fever ourselves, and between the two, if you have to choose, then which is better, to get a CT chest done or
See, if I am getting fever for 1 day, it will be too early for RT-PCR also and CT scan also. If I have mild symptoms, I'll wait. I won't do anything. I will do the RT-PCR after the third day. So the pickup rates of RT-PCR, the RT-PCR being falsely negative, will be very, very high in the first 5 days. So ideally, you have to get the RT-PCR done after third day or fifth day. The maximum pickup rates are on the eighth day. So, but you don't wait for 8 days, obviously, because it might be too late, okay, unless and until you have mild symptoms. So, ideal thing to do is to do the testing on the third day, after the third day of your symptoms, and maybe start treatment as being COVID. Now, if you have access and if you're a healthcare worker, the anxiety levels in doctors are very high. So obviously we get the HRCT done anyways. So I have seen all the doctors getting a HRCT test done till the RT-PCR test is ready. But if you ask me, for a layperson or a patient population, you can, if the symptoms are mild, you can wait till the third day for doing the RT-PCR. If that is negative, you can do HRCT test.
One important question came into our mind is if a post-op patient develops fever and we can't attribute to any operative site problems, then should we go ahead and do a COVID test?
Yes, absolutely. As I said, in a pandemic, any fever, you have to rule out COVID. So rule out COVID, get a RT-PCR done, and one simple thing which we are following in the ICU and which also you can follow is a daily trend of CRP. Now CRP is a cheap test. It is cheaper than CBC also. It costs 300 rupees. Okay, even in the best of the setup, or maximum 500 rupees. And the trend of CRP is important. So anyways, in your orthopedic patients, even if you do a CRP normally, the CRP will be high, okay, for
Right.
any patient. But the trend is important. So if you do a CRP daily and the trend is going down, obviously the inflammation or infection is going down. A three-figure CRP in COVID patients is ominous, and a rising CRP trend is ominous. So that's it. In fact, case reports show that the highest CRP post-operatively is seen in spine surgery. So though many papers say that highest CRP levels are seen post spine surgery.
I think for the want of time, we'll just go to Vivid. Vivid, would you want to show that? I can't even pronounce what is that.
Right.
Which
So I am here to talk about various kinds of protective devices what a surgeon or a doctor can use, whether the surgeon is or a doctor is working in an ICU. So they can try to make them safe as much as possible. And
so, Vivid,
everything is 100%.
if I may interrupt, no.
Yeah.
We may go short on time. So if you come to the
Yeah.
helmet.
Okay. So there is a device called as powered air purifying respirator, which is PAPR, which is usually being used by intensivists all around the world. And this is the device. Okay, something has wrong. Something has gone wrong. Wait a moment.
Vivek, just stop your virtual background. Virtual background on.
Yeah. I'll just go there. Window.
No, you stop the video only.
Okay, all right. So where do I go and change the? Till now it was not coming. I do not know how it started.
You have to click on the arrow next to stop video, and then.
All right. Okay. Got it. Video settings and virtual background, none. All right. Is this okay now?
Yeah, you have to show that and sanitize.
I'm not able to see myself. So, sure.
Neeraj, can you just help him out?
Yes. What is the issue?
Can I see my my image so that I am able to show you what I am.
So what are you not able to see?
I'm not able to see my image.
So go to the
see you.
Zoom.
I can't see the respirator. We can see you.
We can see you.
So
I think Vivid's internet is an issue because he has got disconnected 3-4 times in this webinar.
Vivid, can you hear us?
His internet is an issue.
Now,
just a moment.
Now you can pick it up and show Vivid.
Yeah. Okay. All right.
Yeah. Now it's clearly seen.
Wow.
So, as orthopedic surgeons, we are always worried about the sterility part, and this is something called as powered air purifying respirator, which we usually put on our head. And when we wear this kind of a helmet, this is the HEPA filter which is attached, and this space behind is the place from where the air would enter. This collar gets tight around the neck and it forms a seal. Now, if there is a leakage in the seal, or if the air is coming up from anywhere outside, then there is a button here which would constantly keep on blinking, and it would make you aware that the seal is not tight. Then when such thing happens, that means there is some point of air entry which can be there apart from the HEPA filter. When the button is, there's a button over here, which when you put it on, the motor starts and it starts pulling air from the surrounding, and it would pass through the HEPA filter, and it would fall over your face, which would be under pressure. So what actually happens is it creates a positive pressure inside the helmet, and when the positive pressure is created inside the helmet, no air from outside can come inside, and this air which is coming inside is through a HEPA filter. Now, in such a setting, what actually happens is whatever air you are breathing is coming through a HEPA filter. So there is very less chance of you breathing in a contaminated air, or air which is aerosolized with the virus or infection. So this is what we use. Now, there was a issue that when we use this, how actually we doff it off. Because if we are working in an environment where there is a constant aerosolization and the aerosols sit on the surface of the helmets and everything. So for that, what we can do is we can fix up a hood in this hook, and there's a Velcro. The hood sits on it, and this hood is a disposable hood which can be doffed off very easily. And this helmet can be carried outside into a non-infective area, and then it can be doffed off. So this is one of the devices what we use in the operation theater when we are operating, whether the patient is COVID positive or COVID negative in this pandemic kind of a situation.
This is for 1.5 lakh rupees, Vivek, each?
No, this is for 1,35,000 each.
And how do you source it?
You have certain distributors in Bombay itself, so we can source it through them.
And I believe you have got it for your whole team.
Yeah, I have got it for my whole team, 5 helmets.
So which means you can be encouraged to do a total knee replacement. Would you want to do a total?
Again, as Dr. Kedar has said, that doing any elective surgery is not a right kind of attitude right now. Why? Because you might not know whether the patient is positive or negative. Even if the patient is negative, he might turn out to be positive, which can lead to adverse complications in case that the patient is unaware of. And when we explain the patient that you can face such kind of a situation post-surgically, then they would definitely defer the surgery. Because it's not a life-saving surgery.
Can you show the other mask with your hand, the Honeywell mask which you were using?
Right.
So Kedar, I just wanted your opinion whether just using a plain N95 versus a Honeywell versus that big helmet, what would you really advise? Means should all the surgeons start investing in that helmet because the COVID isn't going away anywhere?
Yeah, so if you have resources, yes, because PAPRs give you the best protection. Okay, even in one experience in the ICU, they had said that PAPR gives you the best experience. Apart from the protection, there's something called as assigned protection factor, APR. So that APR factor is the best in PAPR. It may not be foolproof completely, but it is definitely better than the N95 mask, the protection. The most important thing is breathability, Tushar. In the N95, it is claustrophobic. So a good N95 will choke you, okay, for so long time. And your surgeries go on for at least 3 hours, 4 hours, or maybe more. So breathing in and breathing out is definitely easy. The only problem is that sometimes the visibility may not be that good. So your field of vision during the surgery may not be that good. It is battery operated powered. It has a cost. Okay, it has an investment. And I suppose we have to change the cartridges also during the time. So the filters have to be changed.
The filters would start choking. So the battery would keep telling there is an indication there. So if it is being used over a particular hour, then the filters need to be changed, which is hardly any cost.
So what is the recurring cost for you?
Recurring cost would be around 6,000 per helmet over a period of 5 to 6 months with the limited usage that we have.
So that's not bad. So other problem is you cannot hear. So in the ICU, you cannot use your stethoscope. So anyways, we are not using the stethoscopes with our routine PP. We are using the ultrasound machines. So I think if you cost willing, of course, that's the best protection you get. Now it's not that N95 masks are not good. N95 mask also with a good fit and with a good quality of mask gives you a 95% protection, but again, that's not foolproof. So I would recommend, if somebody can afford it in your setup, why not? You have to go for it.
Correct.
So you go for it. And ventilation is easy, so you can breathe in, breathe out easily.
And you can work for long hours using the same thing.
Absolutely.
That is important.
Absolutely.
Last thing, Vivid, does fogging happen if you wear specs?
No, because no. Why it does not happen? Because it is under positive pressure. So there is no fogging. And there is no humidity collection also around.
Ashish, Neeraj, any more questions?
Yes, I have two questions which I think were, I don't know whether they were answered or not. So one question is from Dr. Amin Shah. He was asking about ozone. Is there any role of ozone sterilization, or have you heard of it?
Oh, there are anecdotal reports about ozone, but no evidence-based papers on ozone.
Okay. And
Sorry.
Dr. Satish Mutha was asking, I think this was answered. What is the best protection for us is in OPD? I think that we had discussed. He must have asked it before.
Yeah, we discussed at length.
Ashish, do you have a question?
No, I just like to ask, I mean, from your experience and the way things are evolving right now in Mumbai, how long, I know it's difficult to say, but how long do you think that we are going to live with this, face shields, PAPRs or N95 in the OPD situation? I mean, I know there will be a risk, but the paranoia which is there right now, how long will it take for all of our community to start accepting this new normal?
4 years.
4 years?
So
4 years for the peak to reach or to have a complete herd immunity in India. That is what has been,
herd immunity is not, meaning currently it's not a reality, because if you see herd immunity takes at least 60 to 80%. By conservative
80%.
estimates, is 60%, but 80% of the population should be affected by COVID.
Correct.
If you count those numbers, it will be a catastrophe, because the sheer volume of our population, there will be so many deaths. So I hope that we don't come to that point where herd immunity should be developed. But the peak in Mumbai should take another month. So we are expecting it to still be there till the next month, July second week or third week. And hopefully things should be better, because we are better off in Mumbai because we have started early. If you see
Exactly.
Thana, if you see the other suburbs, okay, they have started off late. So Pune also is 1 month behind us. So
South Mumbai
that way,
started early and
yeah,
North
and
Mumbai started
now
late. So South Mumbai is
suburbs
settled
are,
completely. The North
that's right. Yeah, perfect. So
So we have
I
to go
feel
through
that
that.
I feel that this virus is going to stay with us for a longer time, and it, like H1N1, it might come back every year. So we have to be prepared for a long
for a
course.
period of
Okay,
time.
and this being a highly infectious, three problems with this virus. It is highly infectious. One, okay, RO is almost more than three. Second is, it is asymptomatic population is significant, or pre-symptomatic population is significant. And the third problem is, currently there is no treatment. Fourth problem is the pandemic. So it has spread all over.
Correct.
What about, did we discuss about the vaccine?
No.
So,
Yeah,
is there
so
any vaccine? I had heard from a pharma company that the Serological Institute has prepared 3 lakh vaccines and they are ready to go for human trials. But somehow they have not been released yet for the human trials.
is still in the pipeline. The Oxford trial is still, the Indian arm is still there, but the vaccine is still going to take time. And if you see the history of vaccines against coronavirus, we have still not got a vaccine for MERS or SARS. We have got it for
Correct.
H1N1. So
For
if
the
you
plain
see
simple
that
reason that it
thing,
keeps on
that's not very
mutating,
heartening.
the strains changing. So it's difficult to have
It will
So,
be very difficult to
short
have a
vaccine.
currently.
Kedar, I think one last concluding thing you should just tell us is that suppose we have fever for more than 3 days today, should we take the new drug Flavi,
Favipiravir.
Flavipiravir?
My take on that is no, because I feel it's a bogus drug.
Oh God.
What do you say about Coronil then?
That's up to Baba Ramdev to tell us. Yeah.
Oh Lord. So that means we got nothing at hand, Kedar.
You have your immunity at hand.
Yeah,
Why are you
except
so
your
negative
immunity,
about it?
Tushar, yeah, except your immunity. अरे अभी इतना गंदे इसमें हम लोग सब काम किए यार.
अरे हम लोग गटर का पानी पी के जिंदा रह सकता है तो ये सब क्या चीज है?
Yeah, absolutely.
Okay.
So we have to be optimistic, Tushar. So we have to be optimistic. And the major part in Mumbai at least is over. So hopefully things will be still better. And by the time most of us may get affected overtly or covertly. So let's hope
Unknowingly,
that
yeah.
we don't land up in those 1 to 5% who have complications. So let's hope for the best.
Right. So Neeraj, I think we've shot our time.
Yes.
From all of us, I think we should thank Kedar a lot. It was
Yes,
just,
yes, absolutely.
it was just amazing.
It was very informative and very exhaustive explanation about various aspects leading
My
to
pleasure. My
or
pleasure.
which
Amazing,
the
amazing.
doctors deal. Yeah.
Yeah, my pleasure.
Neeraj, you have anything?
Yes. Thank you very much. Thank you, Dr. Kedar. Thank you for sparing your precious time. I thank Ashish and Tushar and Vivek to conduct this program very well. And we thank all our viewers. We have reached out to almost 2 to 3,000 viewers who have been watching us. And this is a recorded program. So if you have missed an initial part, you can just rewind it and see it later on. The video will be processed and ready in the next half an hour. Thank you very much and bye-bye.
Thanks.
Thank you,
Thanks.
Neeraj. Thank you very much.